Great. So we have the participants waiting for us. So hey, good evening, everybody. So today's thanks for attending today's session. So here we have Dr. Siddhartha Chakravarthy. So it's my pleasure to introduce our distinguished speaker for today's session, which is titled An Update on the Non-Surgical Treatment of Benign and Malignant Thyroid Tumors, Radiofrequency Ablations, Microwaves, and Ethanol. We are honored to have Dr. Siddhartha Chakravarthy with us. Welcome, Dr. Siddhartha.
Thank you. Thank you.
Yeah. So Dr. Chakravarthy is highly accomplished endocrine surgeon holding an MS in general surgery and an MCh in endocrine surgery from the esteemed CMC Vellore. Currently, he serves as a senior consultant and robotic endocrine surgeon at Apollo Hospitals, Jubilee Hills, Hyderabad in Telangana. Throughout his impressive career, Dr. Chakravarthy has earned recognitions through prestigious accolades such as the Asian Association of Endocrine Surgeons Award and the ICAT Fellowship at Royal North Shore in Sydney, Australia. He further honed his expertise by completing a fellowship focused on non-surgical ablative treatments for thyroid nodules at China-Japan Friendship Hospital in Beijing. So Dr. Chakravarthy is an active contributor to medical communities as an executive committee member of the Indian Association of Endocrine Surgeons. His specific interests lie in ultrasound and ablative techniques for treatment.
He has organized and led numerous ultrasound-guided FNAC and microwave ablation workshops in various locations, including Guwahati and Lucknow. Furthermore, Dr. Chakravarthy has shared his extensive research by presenting at various national and international conferences and has authored 9 publications.
So we are delighted to have Dr. Chakravarthy with us today, and we look forward to your valuable insights on this important topic. Over to you, Dr. Chakravarthy.
Thank you. Thanks for the introduction. At the outset, I would like to thank Josna Madam and IASNM for this opportunity. Can I start sharing my screen?
Please go ahead, sir.
Yes. Yeah. Can you see? Yes. Yeah, non-surgical treatments of thyroid nodules. I have nothing to disclose. This is the outline of my talk. Talk about the introduction, the types, the indications.
Can you, sorry, can you go it into slide mode? Because.
Okay. Shall I stop sharing and then try to share it again?
Please try to restate it. Yeah.
And if you could go into presentation mode, please. Yes, this is fine. Thank you.
This is fine. Yeah, that's good.
And
so there's
just to inform, sorry, Dr. Chakravarthy, to cut you. We have the Q&A session in the last 10 minutes of the session. First, over to you, Dr. Chakravarthy. Please go on with the slide.
Yeah. So I'll be talking about the introduction, the types, indications, the procedure, complication, follow-up, and our experience. So this non-surgical treatment was first described in 2006 by Kim and et al. It consists of ultrasound-guided both chemical and thermal ablative techniques. It's a minimally invasive treatment modality where you don't have any surgical incisions. It is done as an outpatient or a daycare procedure. It's an alternative to surgery in patients with benign thyroid nodules. And as I said, there is no scar at all, and the patient can preserve the thyroid function, unlike in surgery where you have to remove a part or entire thyroid gland. it's a new technology. Whenever there's a new technology which comes into one particular medical field, it takes at least a decade or more, sometimes 2 decades, to develop enough evidence and then to get the regulatory approval, and adoption and training takes time. And then you need financial support. The insurance should start covering this. Now, this procedure is covered by all the insurance companies, even the government insurance agencies like Arogyasri, our local, is covering this procedure. And then there will be a cultural and institutional factors where we have to start absorbing these new technologies. My journey started in last year, October, when I first went to Istanbul, Turkey. It's a tertiary, it's an interventional unit where I had gone to. Because a lot of my patients, I'm a surgeon, I'm an endocrine surgeon. A lot of patients started asking about this procedure, non-surgical, and there's so much literature which is there in the PubMed. So then I went for a week fellowship, and I really liked this procedure, but somehow I wasn't very confident that we were able to do it accurately. So I had my own doubts, but I knew there is a scope for this technique. Then I went to Beijing, China-Japan Friendship Hospital. This is a wonderful unit headed by Dr. Yu Ming An. They do around 60 ablations in a week, and 80 to 90% are all papillary thyroid cancers. So when it comes to this thermal ablative techniques, or the first thing is chemical ablation and the other is thermal ablation. The chemical ablation, we usually use ethanol or the polydocanol. And in thermal ablatives, there are several, but the popular ones are RFA, radiofrequency ablation, and microwave ablation. HIFU is another, which though it's very expensive, but still some people are doing it, but the results are sort of equivocal. And the other, laser ablation, also some people are doing, but somehow the most popular and ones now are radiofrequency and microwave ablation. When it comes to chemical ablation, we usually use 95 to 99% alcohol, and it is the best treatment for a purely cystic nodule. If it's a purely cystic thyroid nodule, it works very well. But if you have a mixed cystic and solid nodule, if there's a solid component, then you can initially, for the cystic component, you can inject the alcohol, and later for the solid component, you can ablate it either with microwave or with the radio frequency. And even for recurrent nodes, if you have a recurrent lymph node, we have done this when I was in Vellore. I remember a couple of patients post-surgery, if you have a node, we used to send them for alcohol ablation to our interventional radiologist. It works by causing small vessel thrombosis and coagulative necrosis. So he's a 55-year-old man who presented with a swelling in front of the thyroid, which was increasing in size, and the FNAC was benign. It was aspirated twice, but it recurred. So you could see this entire thing is the cyst occupying the entire screen of the ultrasound. So we did alcohol ablation for him, and after 1 month after alcohol ablation, it came down to 2.2 centimeters. You could see the normal thyroid, and this has fully shrunk. So this patient, ideally, maybe the standard of treatment earlier, we used to operate these patients. Ethanol. Oh, my video is not playing. So in ethanol ablation, what we do is first, under the ultrasound guidance, we aspirate the liquid. We measure the amount of colloid that we have aspirated. And after measuring the amount of colloid, what we do is up to half to 1/3 of the volume of the aspirated fluid, we inject the alcohol, which is usually 99% alcohol. We keep the alcohol inside the cystic cavity for 3 minutes, and then we aspirate it again. And then we give a saline wash, and we inject it again and keep it for 3 more minutes. And we do this procedure for 3 times. And then what happens is you can see nice bright enhancement of the entire cystic wall. And subsequently, the size of the cyst decreases. When it comes to thermal ablation, there are as I said, microwave, radio frequency, laser, and high intensity, just focused ultrasound, high flow. So the one which we usually use is the ECO. The other company which supplies this generator is Canyon. These two are the popular ones now. The microwave unit consists of a microwave generator, flexible low axial coaxial cable, and the generator is capable of producing up to 1 to 200 watts of power in the form of pulse or in continuous. But thyroid, what we use is the pulse form of this thing, where it is how much we generate, it is totally under the control of the surgeon or the person performing it. And we usually use low power outputs up to 20. We can go up to 35 watts, which minimizes the charring in the thyroid ablation. If you char the tissue too much, then the absorption, the coagulative necrosis and the absorption and the phagocytosis is affected. So this is the microwave probe that is used, and you can see the tip is only 3.5 millimeters. So this white, it is the area where the heat comes, the maximum heat comes from this end, and around 3.5 centimeters is the active tip. So that tip is under our control and it is seen under ultrasound screen clearly, and we systematically burn the thyroid nodule. So in microwave, what it causes, it causes the water molecules to rotate around billions of times per second, which generates the heat. So this heat, the temperature can go up to 60 to 100 or even more. In radio frequency, it's a closed circuit where you have a receiving, this is the generator and the probe and then the receiving electrodes. So in radio frequency ablation, it produces alternating current. This alternating current causes oscillation of the ions. So the oscillation of the ions causes the friction, then the friction generates a lot of heat. So that's the difference between a radio frequency and a microwave ablation. So as I said, radio frequency ablation is a closed circuit and active electrode, and then it has dispersive electrodes. Microwave antenna is an open circuit with antenna and there are no dispersive electrodes. This is the mechanism. So here on the lower half, you can see this is by the microwave ablation. In microwave ablation, as I said, this tip is the one which generates the heat, and the direct heating is more here, whereas the thermal conductance is less. Unlike in radio frequency ablation, the direct heating is less, but the thermal conductance is more. So, and also this is a kind of an ellipsoid. Okay, when you burn it, you get an ellipsoid kind of injury. And this this tissue, if it is charred fully, then there is an increase in impedance. And once the impedance increases, then the thermal energy doesn't, then the surrounding tissue, it doesn't get affected. So in microwave, we usually produce 60 to 100 degrees Celsius heat, and this causes whenever the temperature rises more than 60, it causes cytotoxic effect, cell death, and the cell death causes coagulative necrosis, which destroys and causes phagocytosis by the immune system. That's how the volume of the nodule decreases. It's very important not to burn the tissue. If you burn it more than 100 degrees centigrade, then a carbonization sets in. When the carbonization sets in, this thick scar tissue can't be phagocyzed by the macrophages. So the volume reduction won't be more. Whatever is there is dead tissue. At the end, the patient wants the reduction in the size of the nodule. So now, how do you know, how do you monitor this, and how do you know when you're ablating that you have attained the enough temperature inside? So that, how do we know whether you have coagulated it well? So when you here, as you can see, this is the probe, and when you start burning, the ecogensity increases. So the increase in brightness, once you start this increase in brightness, and also you start seeing these bubbles which come, I'll show you in the subsequent videos. The bubble starts coming. That's the time you know, okay, this tissue is coagulated enough. And then you retract your needle. And also we check the vascularity. So we give dye and we check the vascularity. So before ablation, we check the vascularity, and after ablation, again, we check. If there is any particular area, if there is vascularity, we go back and burn that particular area under the ultrasound guidance. So now the most important indications, who are the patients who benefit from these procedures? They are all benign nodules. One thing, important thing which we have to consider, the indications for surgery and the indications for ablation are the same. Is an asymptomatic benign subcentimetric or 2 centimeters benign nodules neither need surgical intervention nor they need non-invasive like ablations. So these nodules can just be kept on follow-up. So any benign nodule up to size 5 to 6 centimeters can be ablated, or whenever the patient has any compressive symptoms or for cosmesis. Ideally, we would require 2 benign fine needle aspiration cytologists. Or if it's a clear-cut benign nodule on the ultrasound, it's like a honeycomb nodule, and you are pretty sure that it is a benign nodule, even a single FNAC should suffice. In some cases, if the FNAC is looking benign, but it's a predominantly a solid lesion, more than 4 to 5 centimeters, these nodules, it's very difficult to differentiate whether they are follicular variant of papillary thyroid cancer or follicular adenomas. If there's any doubt, it's better to go for a surgical excision. And the next indication is autonomously functioning thyroid nodule called AFTN. This AFTN, if it is less than 4 centimeter, they're ideal for ablation. If you can do it thoroughly, you can ablate the entire nodule, the patient will become euthyroid. They can retain the function and retain the gland. For cystic lesions, solid cystic lesions, it's a good procedure. Recurrent lateral compartment nodes. It's important if these nodes were operated earlier, and then you have some few lymph nodes, those nodes can be addressed by this thermal ablation techniques. But only on the lateral compartment, certain precautions to be followed, like you can't do when they are close to the left level 4, where you get the thoracic duct. Those areas you have to be a bit cautious, and not suitable for central compartment nodes, because central compartment nodes are, they have nerve which is very close by. So the risk of nerve injury is very high when you do the central compartment nodal ablation. Yeah, papillary thyroid cancer, can you ablate it? It's a controversial topic. As I have said, it takes a decade or two to start accepting these procedures. But there is a lot of literature which is coming up for ablation in papillary thyroid carcinomas. I'll be discussing about it. Parathyroid adenomas, yes, it's a very good procedure for parathyroid adenomas, preferably if they are inferior parathyroid adenomas. The problem with the superior parathyroid adenomas, here, the superior parathyroids are usually in the tracheoesophageal groove and very close to the esophagus, and the nerves are posterior to them. So it's a bit of a tricky situation where to ablate this superior parathyroid adenomas. But yeah, if you have an expertise, like I've been in Beijing, where they are highly experienced and very skilled, they ablate all the parathyroids and they do it very well. The next day, parathyroid hormone, which was say 200, comes down to 10 or 20. So they cure those patients. Yeah, the skill is highly important. So we talk about the procedure, how to go about doing this procedure. So this procedure is done in the outpatient as an outpatient, and this is done in the operation theater. So, I mean, this is not like a normal, normal procedure where you can just do it in the outpatient. This is exactly like a surgery. I would say it is more precise than surgery. If you do it well and if you thoroughly ablate it, the chance of tumor recurrence or the complications are very, very minimal. And it's a real-time image. You'll be seeing the entire thing. You have to see the needle all along your procedure. And this procedure is done under local anesthesia. So the patient will be talking during these procedures, particularly when we are going to the posterior part where the nerve is closed. We ask the patient to say E, say ah, so that we are sure that we are not injuring the nerve. And so before we start the procedure, we do local anesthesia. As you can see, this is the strap muscle and that's the thyroid capsule. So we inject plain xylocaine in the thyroid capsule. Once you inject this xylocaine, the entire thyroid becomes numb, and when you ablate, the patient will be comfortably. Sometimes they just sleep off when you're doing this procedure. The most important thing for this ablation is how are you gonna protect the critical structures. Thyroid is very close to important structures. Like this is the trachea. You have trachea here. Then you have the carotid and the IJV. And then this is the esophagus. So this part you can see the esophagus very well. So all critical areas, and then you have the recurrent laryngeal nerve somewhere around here. So this is the area of the recurrent laryngeal nerve. So the most important thing for this thyroid ablation is having a thorough hydro dissection. So you have to create an island of saline all along the thyroid nodule that you are ablating. So here you can see we have injected some volumen. So this causes the carotid, which is supposed to be here. You get at least 5 to 6 millimeter distance. So that much distance is enough when you burn this nodule. So the lateral thermal injury is very, very, very minimal. And what we do is a trans-isthmic approach where we pass this probe through the isthmus. And as you can see in this nodule, we systematically burn the entire nodule. We start from the posterior or the difficult zone first, because once you start doing the superficial, you get a lot of hyperechogenicity. Once it becomes hyperechoic, the vision comes down. So it's very important to start with the posterior most or the critical zone. And we start from here. This is the critical zone. We start from here, and then we systematically burn this area. We move up, we move up. So all this thing will be seen in the ultrasound. So systematically, you burn the entire nodule. Yeah, this is the earlier concept of danger triangle and the danger zone between the esophagus, the trachea, and the nerve. So these are the critical zones. But what I've learned in Beijing, what they do is a very simple technique, but a very useful technique. What they do is they put, like if you can go, yeah, if this is the ablative needle, there's a microwave needle or the RFA needle. So they put one more needle in this critical zones. So they put a needle here. The moment you start burning this needle, our assistant will inject some saline in this area. So the critical zones, the nerve and all is protected, and then you get a distance here. So when you do this, you can confidently ablate the entire nodule. At the same time, avoid injuring the critical structures. Yeah, we divide them into zones. and we start ablating. So when you start here in the posterior part, you divide it into zone, this zone, and then in the end, you burn the entire nodule. I'll just show you this in the video here. Yeah. So can you see the video? Yeah.
Yes.
Okay.
Yes.
Yes, that's right. So this is a patient who with a papillary thyroid carcinoma. Just to orient, this is the thyroid gland. That's the trachea, and we are coming from the transisthmic approach. He had a subcentimetric, incidentally picked up papillary thyroid carcinoma. He went for some ultrasound neck for a neck pain, and that picked up a 7 mm nodule. It was a thyroid's 5 lesion on fine needle aspiration cytology. It was papillary thyroid carcinoma, and he did not have any lymph nodes in the neck. So he was very worried. Then we gave him an option. One was surgery, the other just keep him on follow-up. Then the patient himself asked us, why don't you, can you ablate this nodule? So yes, yeah, we can ablate it. And so this is a short video. So you can see this needle, and that's the trachea, that's the thyroid. So what the black thing is the saline that we are injecting. And so it's very important to inject saline, and this saline is separating the esophagus. This is the esophagus. So the esophagus you saw was being pushed posteriorly. So that's the saline, and that's the esophagus. So we inject saline and we create an island there. So that is the, so this is the nodule, the hypoechoic, that 7 mm is the papillary thyroid carcinoma. And that is the microwave probe, which is inside the nodule, and we start burning it. When we are burning the nodule, my assistant will be injecting saline here. So you can see this black thing which is coming. So I've started burning this papillary in the posterior part. My assistant would be injecting saline. So now, after finishing that part, we are coming from the transisthmic region now. So that's how. Once you start burning it, and how do you know that you have coagulated it enough? When you get this hyperechogensity. When you get the hyperechogensity, and in some benign nodules, you see the water bubbles coming out, then that means, okay, that's enough. You should not over burn it. If you start burning it for a more time, it causes charring of the bad scarring, and then the volume doesn't come down. So that's how we start burning it under ultrasound guidance. So you're burning the entire tumor. Here we keep a margin of at least 2 to 3 millimeters, unlike benign where we stick to the nodule. Here, as you can see, we have gone beyond the confines of the nodule and we are burning it. So we ablate 2 to 3 millimeters surrounding the hypoechoic area. So it becomes hyperechoic. And once we finish, we go to the next. And then we burn that area too. So during this procedure, my assistant is injecting saline in the posterior. So when I'm ablating this part, my assistant keeps injecting saline here. That's the other needle, which you can faintly see where he is injecting saline to prevent injury to the trachea. So part of the posterior aspect, we were not very sure. So we have put a needle from this end. Again, we are doing an hydrodissection to separate the esophagus and the carotid. Yeah, we have injected the needle, and to separate it, we're injecting some saline to separate from the critical zones. And after that, after proper hydro dissection, we start burning the posterior aspect of the, so this is the, so once it is, then we start. So the posterior most part also is dead. So you can see the initial nodule was only this much size, but now when we have ablated it, we have ablated more, and this is the normal thyroid. You can see the clear demarcation of the ablated zone. So this is all the ablated zone, and this is the normal thyroid. There's the posterior most part which we are ablating. So that's a short video about ablation. So now we have to look at the volume reduction. How much, what is the size of the volume that comes down? Every patient is worried. Is it going to disappear? Will my nodule disappear? And the other question that they ask is, how many sessions will I need? Will it get over in one session, or do I need 2 or 3 sessions? These are the questions which we as physicians should be able to answer. So if it is a small nodule, say around 2 centimeters, these nodules, the volume reduction would be more than 90%, 90 to 95% over a 6 months to 1 year. But if the volume is, if it is 4 centimeters, then the amount of the volume reduction that you can expect is 60 to 75%. But even then, if you ablate it thoroughly, whatever tissue is there is the dead tissue, and it is unlikely that it is going to regrow or patient will have any recurrence. So the technique is very important. As I say, it is exactly like a surgery, but it is even more precise. And if you know the right technique and you can carefully ablate it thoroughly, the volume reduction rate would be very good. And recent longitudinal studies have shown that the volume reduction rate is around 93.4%. Second. Yeah. So here you can see the volume reduction can happen even up to an year. So initial volume reduction in 3 months, you would see 67.6 to 20.3%. Whereas after an year follow-up, you see a reduction up to 91.3%. Yeah, what is the difference between this radio frequency or microwave or ablation? Microwave ablation is a bit faster, and it is more quicker to do. Radio frequency ablation takes some time. And what are the advantages of this thyroid ablation? Here in this procedure, the thyroid gland is retained and the function is intact. No need for lifelong medications, unlike in thyroid surgery. And the patient will not have any scars or incisions. And it's a minimally invasive procedure done under local anesthesia, and the patient can be discharged the same day. And if you look at the complication rates in expert hands are comparable as a surgery being done by an experienced hand. The voice change is also less than 1%. The nodule rupture in experienced hands is true, but yeah, when you are starting, if you are not trained well, then you can expect complications. Particularly, they have complications have been reported like permanent nerve injury, case reports of esophageal perforation, case reports of tracheal injury, tracheal perforation. And patient can have, if the contact with the radiofrequency ablation is not good, you can have a skin burn. And yeah, other rare complications like brachial plexus injury, hematoma. These are all other complications, but yeah, it needs proper thorough training, and the risk of complications are very, very minimal. Yeah, now this is a controversial topic, ablating papillary thyroid carcinoma. Can you ablate? Currently for papillary microcarcinoma, what we do is the active surveillance, which is after this publication by Professor Akira Miyauchi from Japan, where they have followed almost 3,200 patients, and almost 2,000 patients were followed up papillary microcarcinoma, and they all were fine. None of them died of this disease. And as you can see, the tumor enlargement was only seen in 6.6% of the patients. And even lymph nodal metastasis was also very, very less. Even in active surveillance, it was only 1.7%. So yeah, one option is for this microcarcinoma, just follow up these patients, no need for surgery. But yeah, there will be, I've hardly seen 2-3 patients who refuse surgery and who are on follow-up for micro-PTC, but majority of them, they would prefer intervention, surgical intervention. But yeah, there are a lot of studies which are come up. Most of the literature as of now is from China, and we have literature coming up from Korea, where they have ablated more than 100 papillary thyroid microcarcinomas. Where I went, they have a follow-up of 8 to 10 years papillary thyroid microcarcinomas, even extended up to 1.5 centimeters without nodal metastasis. Patients are coming on follow-up for 5 to 8 years. There is no tumor at all, and they follow up with thyroglobulin and anti-thyroglobulin antibodies. They're all are very much under control. Yeah, a preliminary study on microwave ablation of multifocal papillary. This is by the same group where I had been, China-Japan Friendship Hospital, for papillary thyroid carcinoma. We follow up these patients with ultrasound. We do it the first month, third month, 6 months, and 12 months. We record the volume reduction, and we also check the vascularity of this nodule and whether there is any growth of the nodule. And we even check, and at 1 month to 6 weeks, we check the thyroid function test, TSH, T3, T4. For papillary thyroid carcinoma patients, there are no guidelines as of now. It is not recommended for PTC as per the guidelines. But yeah, as the literature, more and more literature comes in, I'm sure we'll start for this micro PTC. This probably has to be given as an option to a patient by an expert intervention radiologist or any thyroid surgeon who is comfortable in ablating. So I follow up these patients by checking the serum thyroglobulin and anti-thyroglobulin antibodies. Yeah, how do you follow up a patient with an intact thyroid gland? Each gram of thyroid gland produces 1 unit of thyroglobulin. So roughly, thyroid is 40 to 60 grams. So up to 100 is fine. Anything more than 100, yeah, we take it. Or if it is a metastatic, the thyroglobulin can be in thousands, and even we keep a watch on the anti-thyroglobulin antibodies. Yeah, another more complex thing which we are going to see subsequently, we all should be aware of, is this post-ablative appearance of the nodule. Even if a benign nodule after ablation, if you see this is all the post-ablation nodule. It looks like a typical PTC. So it will be hypoechoic. It will have irregular margins. and this hyperechoic specs will mimic malignancy. So there are patients who by mistake, they haven't told the radiologist that this patient had an ablation. When they go to a routine radiologist, then they say, hey, this is like a thyroid 5 lesion, highly suspicious. And then the patient panics, and then we have to counsel them that, oh, this is the appearance. Talk to the radiologist, educating your radiologists about this new appearance, which we were not used to earlier. So I think most of the endocrinologists or physicians will come across these problems. So everybody should be aware of this new post-ablative appearance of the nodule, which looks hypoechoic, can have irregular margins, and look like a suspicious thyroid nodule. So the history is very important. Yeah, learning curve. And then who should do this? Anybody with good experience in ultrasound and FNAC. People who are treating thyroid, particularly the thyroid surgeon, every thyroid surgeon must have an ultrasound, or endocrinologist must have an ultrasound in his office. It's like a stethoscope or a third eye for us. And we should have done at least 20 to 30 cases of thyroid ablation before you actually get a hang of it, how to do it. We have started in July 2024. We have done 15 patients, 13 of them were benign. One patient was ATP of undetermined significance, AUS. It was less than 2 centimeter, but was looking benign on ultrasound. TG, anti-TG was no. Patient was keen, so we went ahead and ablated that. And I'm using microwave because of the availability of RFA is an issue with my unit. So we have a volume reduction rate of more than 60%. In one patient, it was 90% reduction in the size. And even the alcohol ablation, which we have done, it has almost come down to 0.5 centimeters. To conclude, microwave and this minimally invasive, they're effective options for benign thyroid nodules. It causes significant reduction in the nodule size, improves the symptoms of the patient, and with low complication rate, shorter recovery time than the surgery, no scar, patient can preserve the thyroid function, and the growing evidence and advancement in both the techniques will definitely expand the indications and improve the patient outcome. Microwave and RFA are actually transforming the thyroid nodule management, offering safe and effective alternative to surgery for many patients. Yeah, I am a thyroid surgeon, endocrine surgeon, but I love this procedure, and it definitely has a role, but selection of the patient is very, very important, because we have had patients who were reported post-thyroidectomy as benign, and then they come back after 10 years with follicular thyroid carcinoma metastasis. So you have to be careful when you offer this new, we all are in learning curve. So, but if you select the patient appropriately with a team management, definitely we can benefit the patient. So this is my team. Thank you. And any questions, I would be happy to take. Hello.
Thank you for a very good presentation. I'm Raghu Halkar.
Hi, sir.
And a very good talk, and really true that for benign nodules and microcarcinomas, it may work out very well. Do you use age as a criteria? Do you think preoperative risks as one of the criteria to choose classical surgery versus ablation? Number one.
Yeah.
Number two, what I want to, you already elaborated that occasionally we do get surprises. The pathology specimen says benign, and after 10 years, you get a metastatic follicular thyroid carcinoma. It happens not frequently, but not infrequently also.
Yes.
So the question for me is, in India, when you do fine needle aspiration cytology of the thyroid, do they send it to something like molecular testing for like ThyroSeq?
Yeah.
Or is it a standard of care?
Yeah.
Or how often it's used?
So unfortunately, in India, we don't have this Apharma and ThyroSeq. It's not available in India. But what we are planning to do is we would like to do an FNAC and send it for BRAF. If it is BRAF positive, then we think it is locally aggressive, and we may we may recommend surgery as the first option. That's with regards to the molecular. The first question was about the age criteria. Yeah, extremes of age definitely are high risk. Like a child, if you see a child with, by the time you diagnose this papillary microcarcinomas in a child, I think it's very rare that they usually have a small classic PTC will be very small, but they have extensive lymph nodal metastasis in children. So in children, I don't think this is appropriate. You can't recommend this. In fact, recommending this ablation for PTC is controversial. But yeah, maybe the literature will come true. But my personal opinion on children with PTC, I wouldn't recommend this. Children with benign nodules, cosmetic, definitely this is the way to go where you can avoid the scar. And other point which I would like to say, even in the extremes of age, if it is a papillary microcarcinoma, elderly patient which is confined within the thyroid gland, which is well within the thyroid gland and not located in the posterior aspect, close to the recurrent nerve or close to the esophagus, or it is not close to the trachea, then these patients without any lymph nodal involvement, yeah, I would recommend ablation as the treatment if they don't want active surveillance. Hope that answers your question, sir, Dr. Raghuveer.
Sure, thank you. If others don't have question, I have one more question.
I do have a question. Dr. Halper, go ahead.
Go ahead. Otherwise, I would like to give others time.
No, go ahead first. I'll ask later.
So you made a point about thyroglobulin as a tumor marker after with lot of thyroid tissue, and you use a criteria of more than 100 as a possible presence of thyroid cancer. The only thing is a touch of thyroiditis can shoot up the thyroglobulin high.
Totally agree, yes.
So the question is, do you use a sort of a persistent 100, more than 100 as a criteria, or one-time 100, or you wait for another 3 months?
This again is a controversial, and there are no guidelines to recommend this thyroglobulin measurement with an intact thyroid gland is controversial. First point. Second, when can we use this thyroglobulin? Yeah, if you have a carcinoma of unknown primary, you don't know whether it is from the thyroid or whether you have something, then you get a thyroglobulin, you check the thyroglobulin is in 5,000 or 10,000, then you know you're dealing with a metastatic thyroid carcinoma. But as you said, if your thyroglobulin is say 100, can I take 100 as the cutoff? There are some studies which say, yeah, 100 is a reliable cutoff to take. But if you have thyroiditis, then yeah, thyroglobulin would be elevated. Then you can have anti-TPO may be elevated. In those patients, it would be very difficult to take a judgment whether this patient has metastasis or not. And I'm not sure how you're going to manage these patients, unless if the patient says, I'm very keen, I want only ablation, I don't want surgery. It's a couple of patients, I'm sure you also would come across. Those patients, I'm err on doing a plain FDG PET scan to see that and make sure that there is no other, when your thyroglobulin is elevated and then you do an FDG PET, nothing is there, then yeah, we can recommend ablation. Yeah, but these are all has to be individualized, that this is not any gold standard, which I've told just now. Yes, sir.
Thanks. Fantastic talk. I had a couple of questions about the choice of your technique, how do you decide to go with, say, microwave versus radio frequency or something else, including, laser or something like that?
Yeah.
And are there any, is there any data that one is better than the other, or the side effects are less with one versus the other?
Yeah, that's a very good question, sir. I had all these doubts when I went to Beijing. I mean, what I read and what I saw there was a bit different, a little bit. So when you have a small nodule, if you have a small lesion, microwave ablation works very well. So if you are doing for a parathyroid adenoma, or if you're doing a microwave PTC, microwave ablation works very well. But if you have a larger nodule, so they generally use radio frequency ablation, because in radio frequency ablation, the extent of damage, as I have shown, is a bit more than what actually is seen. So they say that the data is, yeah, the long-term data is almost the same. Maybe a 5-10% people say that radio frequency ablation is better, but those were done with the old machines. But the current generation microwave machines are much better. So a lot of this procedure is mostly done in Turkey. There is one interventional radiologist. So he used to do a lot of radio frequency ablation. Now he has given up radio frequency and does only microwave ablation. But in Beijing, what I have seen is small nodules, they do microwave. If the nodule is large, they prefer radio frequency ablation. They are doing a study now to compare which is better. But as I've said, the literature says that RFA is better for larger nodules, and RFA takes time, whereas microwave is quick. You can do it fast. For parathyroid adenomas and all, microwave ablation is better. Any other questions?
Yeah, is there a cost? So I mean, even in the liver, when there was this debate about microwave versus radio frequency for liver lesions, I think most people were favoring radio frequency.
Radio frequency, yes.
I agree that the data, I mean, the older microwave machines were kind of weaker, and with technological advances, they're matched. But at the same time, I think the radio frequency tuning has improved as well, and the damage. I mean, there are advances in both, so it's
Right.
and it's always good to have a choice of things. I mean, we've even done ethanol for some of those tumors in the liver, which I'm sure people don't want to use that much in the thyroid to begin with, because those are kind of smaller lesions. But is there a cost difference and the recovery period between the two? Because
it's actually the same.
Okay.
It's the same. The recovery is also the same. The cost is also almost the same. There isn't much of a difference between radio frequency ablation, because the probe everything, there isn't much of a difference between these two. The echo is a bit cheaper for the microwave, and Canyon is also there. It's also very effective. It's a flexible probe, the 18 gauge Canyon, which is also again a Chinese company. The echo, the RFA, what they were using is the Ethicon, rather the, what do you call that? So the Ethicon company, that is the RFA machine which they were using, and it was very good with them. Even the Canyon has a RFA machine, which is very good.
And who follows these patients for follow-up?
I am an endocrine surgeon, but I've been using this ultrasound for almost 14 years. When I started my training in 2010, I started using the ultrasound, and so I follow up my patients regularly, along with my endocrinologist, whichever endocrinologist refers to me. So we both follow these patients. If it is a carcinoma or something, we usually include our nuclear physician in our team.
And do you have any? So you showed a good case of how it looks on a thyroid ultrasound, that it can mimic a carcinoma with heterogeneity and enhancement. The echogenicity pattern is kind of similar to carcinoma. So if you don't have the history, it may be read as a thyroid 5. Do you
Yes.
have any cases where how it looks on a thyroid scan, radionuclide like I-123 or I-131? Well, usually I-123. How it looks like? Does it look like a cold nodule that we typically associate with cancers, or I'm assuming it's going to be a cold area, but
Yes,
just curious.
it'll be a cold nodule because there won't be any vascularity. So I haven't shown those images. Once after a week, when the patient comes back, also when we do an ultrasound, the entire nodule will become avascular. So you'll only see patchy vascularity. So when there is no vascularity, I think the iodine 131 or the technetium 99M will show it like a cold nodule kind of thing. And ultrasound, yeah, definitely. When I went first to Beijing, their patients were they're coming for follow-up for almost 8 years, 7 years, and the tumors had disappeared. But the ones who had 4, 5, 6 months who had the ablation, when we look at them, the first time, hey, is it PTC? I'll ask them, no, this is a benign nodule. Then they used to show me the old ultrasound. Then I used to compare, and oh man, that looks, so it was yeah, it will, you'll also see these patients. I'm sure in US also a lot of people are talking a lot, and a lot of people are doing this ablation, radio frequency, microwave. So you will come across these problems, and the patients will panic. So we should be aware of this new post-ablation appearance and counsel the patient accordingly.
Yeah, fantastic. So if I'll reach out to you.
Can I ask one question, Amol?
Yeah, go ahead.
The American Endocrine Surgery does not recommend even fine needle aspiration on parathyroid adenomas. They ask us to avoid it, mainly because there is a chance of seeding. And seeding can happen, and then patient may recur parathyroid adenoma after many, many years. So what is the experience with this?
I do
because
agree
the
with that.
probe,
I do agree with this point of what you said, sir. Doing parathyroid adenoma, we usually don't recommend fine needle aspiration because we are scared of an entity called parathyromatosis, where you have tumor seedings, and we have, even after operation, when you're operating, you have to take it intact. Otherwise, the tumor seedings, we have operated on patients who had multiple parathyroid local recurrences. So it's called parathyromatosis. That can happen with FNAC also. So when you are ablating, again, you are worried, isn't it? How will this, I'm going to break it, and will the patient again have parathyromatosis? Yeah. If you are a novice, if you're not experienced, then you will definitely have this problem. But if you are an experienced interventional in ablating these procedures, then you can ablate it thoroughly. In fact, if you ablate it properly and you kill the entire cell, the chance of recurrence is extremely low. And there are case reports of parathyromatosis after microwave ablation also. So yeah, this is as I said, this is equivalent to surgery. You have to do it very precisely, taking all the precautions. Then the chances of complications are comparable, or in fact lesser than surgery as per se.
In your experience or in Chinese experience, a patient who has been RFA or microwave ablated, by chance, if he goes after that for a surgery, how does the histopathology specimen look, or how much of a complication it causes for the pathologist to decide what it is? Because we had a case like that recently, and fortunately there were no, they would say this was, there is no cancer cells at all.
Okay, so the two things, sir. One, whether what happens is it causes necrosis. So if the tumor, the entire tumor necrosis, or obviously you are subjecting the patient to surgery, means there is a recurrence, or it wasn't ablated fully. So that's the reason for. So you will see a part of the area with a lot of necrosis and phagocytosis, those kind of appearance. The other area you will see the tumor. The second question, will it be difficult for the surgeon if he is operating, after ablation? So we have operated on patients who underwent ablation, but we didn't really find any difficult, because it's just a needle which is inserted into the tumor, and usually in 1 or 2 or 3 points, and we don't go outside the thyroid. Whatever we do is inside the thyroid, inside the nodule. So as a surgeon, we generally should not face any problems after ablation.
Thank you. That's a good thing to know.
Thank you.
Yeah, good things to know. I might reach out to you and ask you to send some of your cases with pictures for us for educational purposes, with
Definitely, sir.
the thyroid scan as well as the ultrasound post ablation to see, just for educational for our residents as well. And I'm assuming, since you're doing long-term follow-up on these patients, you have data that you have either published or are going to publish.
It took me, I'm learning this for the past 1 year. I bought my own machine and I have ablated so many chicken livers, because I am not a interventional radiologist. So if we are going to do it, so you need to be very skilled, and the skill comes with practice. It's like playing a video game. So I've been doing that, and now I have a lot of patients lined up for this procedure. So we are going to ablate 2 parathyroids in the next week, and a lot of thyroid benign nodules lined up. So now I got the confidence of doing it. So after I came back from Beijing, the most important thing, as I said, is hydrodissection. It's very important. So create an island. So that hand-eye coordination is very important. So I was practicing that, and now I'm confident, and we started doing after 10 cases. Yeah, it becomes much more easier. This is the PTC which I had ablated all, and we could thoroughly ablate the entire PTC. So yeah, it will come with experience, and definitely we are keeping a data of all this, and we're going to publish it subsequently.
Awesome. Good luck. Looking forward to some articles from you down the road.
Thank you, sir. Thanks.
Just to complete the story, in US we have occasional few centers that do endoscopic thyroid surgery to prevent a scar on the neck, especially for a film actor or somebody public figure. They would go through the axilla and do it's almost like a notes surgery. Are there any centers that do it in India?
Yeah. I am an endocrine surgeon, sir. I do this notes, natural orifice surgery. So we do this, what we call as a transoral endoscopic thyroidectomy, which is notes. Whereas the axillary approach is not notes, because it's not going through a natural orifice where you are trying only to displace the scars from the neck to the axilla, but it's not a natural orifice. Transoral, the vestibular approach, we go from the lower lip, and then I have done around 65 patients of transoral endoscopic, particularly patients who have keloid tendency, and young women who are worried, people who are in the media who have to in the limelight. So those patients, we offer this. And we have done a couple of parathyroids also, particularly 3 of our parathyroids that we did. All of them had keloid tendency, bad spontaneous keloids. An amazing procedure, transoral endoscopic thyroidectomy. But now, looking back, in the future, I would tend towards ablation. If the ablation fails, then yeah, we would take them for surgery. So, but yeah, ablation has a definite role in select patients, and I look forward to learn this more and more.
Thank you.
Thank you, sir.
Awesome. Thank you. Great talk.
Thank you, sir.
There's a question in the chat, I think. How do microwave ablation and radiofrequency ablation compare in terms of effectiveness, safety, recurrence? I think you answered that. I asked the same thing.
Said that. Yeah, it's almost the same.
Sounds good.
Yeah.
All right. I think if there are no more
Okay,
questions, we
yeah.
can
Yeah.
appreciate it.
we
We
can-
appreciate your talk.
Yeah.
Thank you.
Thank you, Dr.
Thanks.
Chakravarthy, for the great talk.
Thank you, madam.
Isha
Thanks for
had
this
to leave,
opportunity.
so yeah. So we'll be ending the session then. Thanks
Thank
a
you.
lot.
Thanks a lot. Thanks everyone for the time.
Thanks, Josna. Appreciate it.
Oh, yeah. Welcome. Welcome. I had been waiting to listen to this actually.
Good.
This is one of the most, the one I was most interested in. Yeah.
Yes. Yeah. Awesome.
Yes.
Looks like you have a great thyroid team there.
Yes, wonderful. And I'm lucky to be working with them. Yeah.
Me too. Thank you, ma'am.
Mm.
All
Thanks.
right. Bye all.
Thanks.
Happy
Bye-bye.
Diwali.
Bye.
Happy
Thank
New
you.
Year.
Wish
Happy
you the same.
Diwali.
Happy
Happy
Parva.
Diwali to all.
Thank you.
Thank you.